Hi, good morning, everyone. This is Mike Witte, Chief Medical Officer at the California Primary Care Association. Like the rest of you, sheltering at home and wondering when this will end. One of the things I do remember is back on March 18th when our governor began the isolation at home, sheltering in place executive order, that one of the first things he said, to his credit, is that this is a moment in time. This is not the new normal. And it's pretty hard to kind of envision that as not the new normal when here we are, about 2 weeks, not even 2 weeks into this way of living. And it's hard to kind of even remember what it was like before, at least from a work perspective. We are in a position where most of what we deal with is information sharing. We're not literally putting our hands on things, most of the time, and making things. So a lot of us can work from home. However, there's a large number of all of us and a lot of you who are putting yourself in harm's way many times every day to be able to literally touch this problem. And I can't say more about how important and essential your work is right now to be able to get through this. One of the things that I have sent out to many of you, and many of you have also seen otherwise, University of Washington sent out a scenario of what the likely mitigation and likely bell curve of illnesses, COVID-19 illnesses and deaths would be here in California, given both what the trend has been in other places and also what our mitigation strategies in California have been. And if we continue those mitigation strategies, what we're likely to see. And what that scenario, that predictive scenario showed is that we're likely going to have the maximum need for resources, including ICU beds, including regular hospital beds, including personnel, on April 24th through 26th. Now, these are always guesses, but basically toward the end of April is when we're likely going to see the peak of the problem, where there'll be the most number of both hospitalizations, ICU beds needed, ventilators needed. ICU beds and ventilators are almost kind of the same thing, and unfortunately deaths. That prediction says that by July 4th, there should be 0 deaths per day in California. Now, that relies on many, many things, and particularly us continuing to mitigate, to be able to shelter in place and to continue the same kinds of restrictions in our lifestyle that we've been accommodating to over the last 2 weeks. But if we are doing this, let's say, until the middle of June or till July, we're looking at April, May, June, at least 13 to 14 weeks of a total interruption of our normal lifestyles and our economy. That's pretty amazing to look forward to, and much less to look back on when we've actually gone through this and what the effect is going to be on all of us. In the meantime, both our CEO, Carmela Castellanos-Garcia, and myself, and our head of government affairs, Beth Malinowski, have been on the phone with the governor's office and also with leaders of many of the large healthcare stakeholders in the state. And over the weekend, a letter got created which has on its letterhead several of the major healthcare stakeholders in the state, including the California Medical Association and CPCA, as well as the long-term care associations, the podiatric association, pharmacy association. And the letter is basically to say to the governor, we need your help in terms of being able to provide more points of access for care as this COVID-19 pandemic crests in California. And the sense of the letter is that we need to be able to free up the supervision of both our resident doctors, resident nurse practitioners, physician assistants, midwives, and also to allow for credentialing to be eased for being able to work in hospital and or emergency situations. The import of this is that, and it's likely that the governor is going to see this favorably, is that we should be able to work and work much more freely without the kind of supervision that has been necessary from physicians supervising both NPs and PAs, and also for many of our medical residents to be able to actually work more independently. This also calls for some other things, like retired doctors who coming back into practice, whose licenses might have even lapsed, to have doctors that have not matched in residency programs to be able to work even though they're not currently in a residency program. So there's a lot of different elements of loosening up the restrictions on practice that can seem kind of scary, but with the right kind of supervision by currently practicing supervising physicians and other healthcare professionals, nurses, NPs, etc., that the notion here is that it becomes much more likely that we can provide the kind of access that's going to be very important for this period of time. One of the things that this leads to is what are the staff positions that are going to be necessary to actually be hands-on. And a lot of you know this already because you've been doing this work. But this is going to be a continuing drama, and as we move forward, how can we minimize the amount of danger that we're putting our staff in to be able to adequately take care of people? What, of course, this really implies is much more virtual care, and there has been and continues to be much more advocacy for being able to code and bill for that kind of care, that is telehealth and telephonic care. And that is a work in progress, but for our FQHCs, there is much assurance that we will be able to recover our PPS rate for nearly all of this kind of care when it's done by a billable provider and documented well. So that's extremely important in terms of safety and also appropriate levels of care. The other thing that is important, I think, for us to all recognize, and obviously a huge issue, is the amount of PPE, personal protective equipment, that is available and is hopefully and should be coming online to become available for those people who are putting themselves in harm's way, and also patients that will need it because they are positive or are being quarantined, but people that actually require or need some kind of protective devices. So that in that light, because there's not enough, CalOSHA has come out with guidance for this, which you can find online, CalOSHA's guidance for safety. And the notion in this is that there isn't enough equipment. So how do you then prioritize this, and what is okay, what is adequate in terms of being able to provide an efficient level of protection and safety for different levels of care that are being given. I think that would be important for you to access that. If you need it and you can't find it, please get in contact with me or those of us here at CPCA on the emergency preparedness team, and we can get you that guidance. Another thing that's going to be coming up and you're already hearing about is redeployment. Much of our staff who are not part of that essential on-site staffing or are not actively doing telehealth or telephonic care, and eventually more of our billable providers and people that are doing care now will be asked to redeploy, meaning that they'll be asked, and a lot of people, including retired physicians, retired nurses, etc., and you've seen this in New York State already, are redeploying to be able to be available in hospital and doing the kind of work that may well be required in these new beds, new ICU beds, and also field hospitals that are being put up to be able to take care of the likely number of sick patients that may peak in late April, as the scenarios are indicating. So stay tuned for that. There are right now two directions to go in terms of redeployment. One would be under what's called MOAC, which is MHOAC. That is actually a way of being able to get the workforce out into the community, and each one of our counties, each one of our 58 counties, has a MHOAC, a MOAC, that is usually staffed by a healthcare professional to be able to coordinate and move our members into the right positions. The other way of being able to redeploy would be to volunteer. And there are different ways that you can volunteer. You can find some of those online. I know the California Medical Association has developed a Google Doc for this. And we want to be really careful, I think, in our FQHCs to recognize that as employees of our healthcare centers, we want to make sure that we're coordinating with our needs in our community that we're already deployed to do, and then also working with our C-suite, basically the administrators of our centers, to be able to appropriately redeploy the clinical staff in ways that can be most effective during the crisis. So I'll stop, and I have only one more thing that I want to really focus on right now, and that is that what next? And I just want us all to continue to think about this really hard and think about it more as we move forward. And that is that this crisis will get over, as I said at the beginning. This crisis will be done. It's likely that we will be looking back on this by the middle of the summer, if not sooner. That's a long time away right now. But when we are looking back on this, then we turn around and we look at, well, what is next? How are we going to work moving forward? What has changed for the future that will not go back to the way it was before? And some of this is where we've been headed in the first place, which is toward value-based care and toward trying to see people in the appropriate ways and get appropriately compensated for that. But how does that work? And how can we partner with the right organizations and the right payers, health plans, the state, Department of Healthcare Services, et cetera, to be able to find the best way to continue care? And the last thing about this right now that I think of is, how can we minimize the chance for this or something just like it coming back and be best prepared for not having that happen?
Any other questions that you have, don't hesitate to be in touch with us, our emergency preparedness team, and also myself, Mike Witte. Happy to help you in any way that we can.